Hi, this is Brent Betts showing a case of routine cataract surgery on a moderately dense cataract. The first step is to make a small incision, which we call paracentesis. It's parallel with the iris. The blade I'm using is 1.1 millimeters in diameter. Periodically, you notice that we wet the cornea to keep the view of the cataract clear. I inject the eye with preservative-free lidocaine and phenylephrine to help with anesthesia and keep the iris dilated. Next, I inject a viscous substance, which we call viscoelastic, into the front chamber, anterior chamber of the eye. This fills up the anterior chamber, protects the cornea and iris from any trauma during the surgery. I'm making a small partial thickness incision in the cornea called a Wong pocket and making the main incision. It's what we call a triplanar incision, using 3 small movements to help with the incision that can close on its own. The incision width is 2.5 millimeters. I'm using a device called a cystotome to make an opening in the capsular bag, which is the outer layer of the cataract. After this, I introduce a tool called the Utrata forceps, and I grasp the edge of this capsule that I've exposed, and I make a circular motion to make a circular opening in the capsular bag. We call this a capsulorhexis. We found that the circle is the strongest shape in regards to tension, and so you want to make this as round as possible. The cataract has to be loosened from the capsular bag. This is done using a salt solution on a cannula. Sometimes an air bubble shows up in the cannula, they're easy to remove. The goal is to completely loosen the main cataract from the capsular bag. Your goal is to protect the capsular bag, keep it intact for new lens placement. You could see a fluid wave going behind the lens. I'll rotate the lens just to ensure that it's easily maneuverable, as this makes the surgery much safer and easier. The main tool that we use is called a phacoemulsification probe. It uses ultrasound to help us break up the cataract and remove from the eye. I'm going to remove epinucleus and some viscoelastic material. Epinucleus is the outer layers of the cataract. And then using a second instrument, I'm going to use a technique called a double chop technique, where I bring the instruments together, splitting the cataract in half. Then I will do a cross chop, where I break one of the halves into a smaller segment, kind of like splitting a pie into 4 or 6 pieces. This is where the phacoemulsification probe is used to bring that smaller piece to the center of the eye, where I can use a foot pedal to introduce ultrasonic energy to help break up the cataract into liquid and remove it with a vacuum. The second instrument, which we call a chopper, in this case this is a Nagahara chopper, aids me in breaking the cataract into smaller pieces. It also helps protect the posterior edge of the capsule, which is only 10 to 13 microns thick. It's easy to break, and if it breaks, you will see vitreous in the front chamber of the eye, which is a complication of surgery. One of our goals in cataract surgery is to never break the posterior capsule. Half the cataract is removed at this point. I rotate the cataract in order to make it easier to remove again. I'll use a little ultrasound energy to grab the cataract and then use my chopper to break it in half. My chopper is a double-ended chopper. The other end is a spatula called a Koch spatula. I like to use this for the last parts of the cataract surgery once it's all broken up. I think it's better for protecting the posterior capsule. Part of the reason that the cataract is broken into smaller pieces is we end up using less ultrasonic energy, meaning that the cornea is less swollen on the day after surgery and people end up seeing better quicker. Also, long-term outcomes are better when there's less corneal swelling. Now that the dense part of the cataract is out, there is material left called cortex. It's the outer layers of the cataract. It's a stringy material. This instrument is called automated irrigation and aspiration. There's no ultrasound energy, but it does have a vacuum and it releases fluid constantly. I grasp the edges of the cortical material from the capsular bag And with a foot pedal, I use a vacuum to build vacuum energy, vacuum power, and bring the cortex to the center of the eye where I can suck it out. You can see the capsular bag's much clearer at this point. I'm polishing the the underside of the anterior capsule here. There are always residual cataract cells left behind, cataract or lens cells. The more of these you can remove, the less scar tissue you end up getting after the surgery. Additionally, I do gentle polishing of the posterior capsule with the IA device. I also use a device called a Terry squeegee, which is a silicone tube attached to a cannula. There's additional type of viscoelastic here, so I slowly inject the viscoelastic and polish the posterior capsule. This aids with improvement in visual acuity after surgery and also minimize the risk for scarring on the back of the posterior capsule, which is a common finding after cataract surgery. The lens is preloaded into an injector, and I twist my hand to push it into the eye. It's kind of rolled up like a taco. The lens is made of a hydrophobic acrylic material. I'll position it with my Coke spatula. You can see the little arms of the lens are stuck together, and I gently lift up on those to break the adhesions. And then the lens kind of folds out into the orientation it wants to be in. Residual viscoelastic material is removed with the IA device. If viscoelastic is left in the eye, it will cause an intraocular pressure elevation for about a week after surgery. We try to minimize that by removing as much as possible. I like to use a cannula to change the flow of fluid in the eye to see if there are any small cataract pieces that are left behind. The lens should be centered as much as possible. Next, I will hydrate my Wong pocket, which will help with closing the wounds. You can see that the cornea gets swollen in those areas. That's that whitening. I check with a special sponge to make sure that there's no leaking. The eye pressure is fairly high at this point. I'm going to decrease the eye pressure by pressing on the paracentesis. This cannula has an antibiotic. It's a preservative-free moxifloxacin in a 1 milligram dose. I only inject a small amount, about 0.75 milliliters, and then I decrease the pressure again. You can approximately tell how much the eye pressure is by pressing on the eye. I hope you enjoyed this surgery. Please subscribe to my YouTube channel for more educational, interesting surgical videos. Thanks again for watching.